Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday and it's time for my Roundtable. The Roundtable is a chance to sit down with a multidisciplinary group to have discussion about perioperative care and improving the quality of what we do every day.
Top Med Talk.
I'm here with Monty, Mythen, Editor-in-Chief, and I'd like to introduce our first two guests today. And the first one is Barbara Slawski. She is the director of the Perioperative Medicine Summit and an internal medicine physician from the Medical College of Wisconsin. And we also have Dr. Stephen Cohn. He is the co-director of the Perioperative Summit as well, and an internal medicine physician from the University of Miami, the Miller School of Medicine. So thank you, Dr. Slawski and Dr. Cohn. Can you give us just a little bit more about your background? Barbara, why don't you start? Tell us a little bit about where you're from and how you're involved with SPACI.
Right, so I'm an internal medicine physician at the Medical College of Wisconsin. I've been doing perioperative medicine for about 15 years. I started by running a preoperative clinic that probably saw about 3,000 patients and was in complete disarray when I started, to be honest, and really enjoyed what I was doing, and eventually became the inaugural chief of a section of perioperative medicine that included both preoperative care and inpatient postoperative co-management of medically complex surgical patients. So as part of that role, I manage clinical operations, faculty development, workforce planning, those kinds of things. I got involved with SPACI actually through meeting Amir Jaffer, who was the director of the summit at that time and came to the second summit. So I've been to every summit since the second summit. And after getting to know Amir, Stephen, others, I think became the co-director of the summit maybe 5 or 6 years ago, somewhere around then.
Yeah.
So I've been involved in the summit for a long time and really believe in the mission of the summit because it involves a multidisciplinary group of providers, which I think is what we need to take good care of perioperative patients.
Yeah, definitely. Well, I think you've done a fantastic job. I mean, so far, it's been great and lots of good feedback from all the participants. There's a huge crowd here. So when you talk about multidisciplinary, what are some of the specialties that you see at the meeting?
So we see about half of our audience are anesthesiologists and internists, but it's not just physicians. We have a lot of advanced practice providers. We also get surgeons that come. We have a couple of surgeons that I think come every year. Isn't that correct, Stephen?
Yeah, usually orthopedics.
Yes. And so it's just wonderful to see people from all types of training come to this conference and come together to learn about what is the newest evidence in taking care of the surgical patient and how can we improve outcomes and do it safely and efficiently.
Yeah, that's great. Well, we also have Dr. Cohn, Stephen Cohn, here with us. Can you give us a little bit about your background and your involvement with SPACI?
Sure. I'm one of the old guard perioperative medicine people. I have the white hair. I got interested way back when I was a resident, and I did the consult service, and I didn't know what to do. And the only thing available at that time was Lee Goldman's original cardiac risk index. So I felt unprepared to do things, and I made it my job to learn as much as I could, and I became the local expert and then just took it from there. In 1986, I was in New York at Downstate Kings County Hospital in Brooklyn, and I set up our first pre-op clinic back in 86. I also ran a medical consult service. I was recruited down here by Amir Jaffer, who was a colleague of mine, and I came down in 2011 to Miami to set up the consult service at the University Hospital, and then I took over the pre-op clinic at the University of Miami as well. So I basically have been doing perioperative medicine for 35 years plus. I was involved with this meeting since the beginning. As I said, I was a friend of Amir's. So from the first one we had at the Cleveland Clinic 15 years ago, I've been involved, and in the last 5 to 10 years or so, I've been a co-director as well. And I think that this meeting is what we call, it's a little bit different. It's not just giving you basic information. It's a state-of-the-art and update type of meeting. It's now under SPACI's sponsorship, and we get the best experts we can find. We get the most recent information, and we usually start off, as we did this morning, with a little update of the literature to give people a flavor of what's out there, what's new, and then we can take it in more detail from there.
Yeah, I love that about the meeting. It's when you first sit down, it is a lot of information, but I think it's great because you have to have that foundation, and it's great to have the updates. I'm excited to hear a little bit more about the format for the rest of the meeting, because it's not all just in your face evidence all day long, right? There's some other things that you guys do through the meeting.
Sure, we have what's called rapid fire sessions. I did the first one earlier. These are 15-minute presentations. Real hardcore, just the facts, and a 5-minute question and answer period. We have some panel discussions. One will be on pain management. And then we have breakout sessions on a number of topics. And there'll be perioperative medication management, cardiac conundrums, and the like. We also have a poster session. We have a fair number of people presenting posters, and we'll be judging them. And tomorrow we will present the top 3 for oral abstracts.
Great.
And we have a challenging cases expert panel that Stephen will be on the panel tomorrow.
I forgot about that. Yeah. Barbara will be trying to stump us.
Yes, so they don't get to see the cases in advance of the panel.
Oh, that's fun.
And that makes it a little exciting for the panelists and the crowd.
That's right.
A little anxiety.
Put you in the hot seat there.
Yeah. The other thing is the use of the audience response system, I think, is helpful to engage everybody and to actually see what people think or what people know, because we may be under the assumption that they know some of these things that they don't. So I think that's very helpful in guiding us as we're giving our lectures.
Yeah, definitely.
I think one of the really anticipated pending panels is the one with P.J. Devereaux and Lee Fleischer.
That's what everybody's talking about.
To look at the difference between the guidelines and understand the evidence that shaped the guidelines and why they're different and the different perspectives on that evidence. And I'm really looking forward to that one myself.
Yeah. And it's that specifically on MINS?
That's a separate topic on manage and MINS.
Yeah.
He'll give a separate talk on that.
Oh, that's right. Yeah.
And the Frank Machota lecture. Frank Machota was one of the people with Amir Jaffer who started the summit.
Ah, gotcha.
And unfortunately, he passed away several years ago from colon cancer. But he was one of the first hospitalists at the Cleveland Clinic, and he set up their big impact center there, and has been involved with perioperative medicine and hospital medicine for the latter part of his career. So the memorial lecture is being given by Daminda Vijay Sundra, and he'll be talking about the METS trial and how that fits in and how that may reshape guidelines as well. Yeah. His second part is going to be talking about other forms of exercise testing.
Yeah, I'm really excited to hear Daminda and hear about METS. We've talked a lot about METS, actually, on Top Med Talk.
Yeah, we've done a number of recordings. There's still considerable controversy in some areas about the interpretation of the results, but we look forward to that, going into that further, as often happens.
That's right.
Do you mind if I ask a couple of questions about
that's what I was just going to say, if you had
session? I really, we're all reflecting on the fact we really, really enjoyed that first session. And we were discussing a moment ago about a couple of the takeaways with regards to the meta-analysis about ACE and ARBs. And, I mean, my takeaway in it was that it seems to be the right thing to do to stop the ACE and ARBs, because there was no harm associated with stopping the ACE and ARBs, but there was more hypotension if you kept the ACE and ARBs going. Was that right, Stephen?
I believe that's correct.
And we have to accept his meta-analysis, etc.
Right. There's an ongoing controversy in terms of what we should do with this and the anesthesia. When I was in New York, I almost never stopped ACEs and ARBs. In all the years I was there, nobody complained it was a problem. And then I got down to Miami, and they said, oh, no, you can't give these drugs at all. So what we've done, and I think I highlighted that in the little small RCT that I presented, was that clearly it's associated with more intraoperative hypotension. So if you stop it, you'll prevent some of that. However, patients who were excluded from that trial and patients that we were more concerned with for stopping were patients with heart failure or patients with uncontrolled hypertension. We don't want somebody canceled because the blood pressure is high, and some of the patients may be so fragile that they may potentially have a problem if you discontinue the drug, certainly 24 hours or more before. Holding the morning dose probably is okay, but again, we just don't have enough hard evidence for me to say that.
I think that there is a large RCT certainly going on in the UK. Gareth Ackland is the principal investigator. It's been quite well funded. I don't know how far advanced it is. It wasn't in your lecture and maybe not often talked about. When do you restart? Do you have any restarting rules?
Well, they should be restarted, we say, as soon as possible when the patient is hemodynamically stable post-op. I would say the next day or certainly the day after that, and there is some evidence that if they're not restarted within either a 14-day period or a 30-day period, they've been associated with poor outcomes, increased mortality from VA studies.
Because one of our experiences with enhanced recovery is as we're getting everybody up immediately post-operatively, and many patients have orthostatic hypotension, as the ACE and the ARBs often don't help then. So we've switched to the sort of can they mobilize before we... Is that reasonable? I
think it's reasonable. I would say that should happen within 48 hours. So I think that being off the drug for a couple of days is probably not going to be harmful.
May I ask one more question on that
please.
session?
Yeah.
So we were also reflecting on the fact that there's no association between the ACE-associated hypotension and poor outcome, whereas the next study you presented, which is another analysis from Vision, I think, Abbott et al., A&A June 2018, MINS defined as a troponin of greater than 0.03 nanograms per mil, etc., all familiar with that. Tachycardia and hypotension, this time with a systolic of 100, was associated with a poor outcome. So there seems to be a disconnect between those two observations. Is that a numbers thing? Or
I think it's a numbers thing to start with, because they do have different numbers, whether it's systolic less than 100, less than 90, less than 80, less than 60, whether you want to look at just that or whether you want to look at mean pressures. And I think that that's going to be a potential problem when you try to compare one study to another. The other thing from the Vision study, I believe, is that it did show potential for harm, but it was a composite endpoint including MINS, and it barely made statistical significance, whereas none of the individual components were statistically significant. And if you substituted MI for MINS, the whole composite was not even statistically significant. So, again, a lot of controversy. What should we do? It would be nice to have that randomized controlled trial where we know what's what and we have a defined number for hypotension and complications.
Yeah.
And we'll add one more, but
Please.
This time it's for Barbara.
Do it. Yeah.
I think it was in your session, Barbara, was the aspirin.
Yes.
Which aspirin?
Yeah, the aspirin.
Aspirin versus the DOAC.
Because we were talking about the DOACs, we went through the other trials, but in particular, I think you presented the results of a large observational study from Denmark, I think it was. Is that right? Retrospective, 42,000 patients, primary total
the
knee.
total knee arthroplasty and
And
VTE prophylaxis, yes.
And what I took from that was aspirin seems pretty good as a...
Non-inferior in that study, yes.
Can you expand on the study a little bit more, just so I'm clear as to what my real takeaway should be and how it might change my practice?
So this was a study where this was actually in the Michigan Arthroplasty Registry.
Okay,
we're talking about the VTE
right,
prophylaxis one, where the authors or the clinicians in this study used the American Academy of Orthopaedic Surgery guidelines, and they could choose between aspirin or anticoagulants as their choice of VTE prophylaxis. So the authors lumped any anticoagulant into a single group and compared that to aspirin as, for VTE prophylaxis for efficacy. The baseline characteristics of the study populations were a little bit different. As far as the number of bleeding disorders and VTE history between the groups. So that's a limitation of this study. But between aspirin-treated patients and anticoagulant-treated patients, there was no significant difference. So they concluded that aspirin was non-inferior.
So I wrote down, I think the PE, DVT, the bad outcomes related to clotting was about 4.8% in the none and 1.2 to 1.4%, but about the same in the aspirin and the anticoagulated one. But there was some baseline imbalance. I've not seen, where I've worked, aspirin being used as one of the options for DVT prophylaxis. Is it common?
It's very common in the United States, and actually, at least in this Michigan study, in 2015, the use of aspirin in total knees exceeded the use of anticoagulants, which I don't know if Stephen sees that at his hospital, but it's extraordinarily common at ours now. The surgeons seem to prefer this.
Interesting.
There have been some other studies, though, preceding this one looking at anticoagulants and aspirin. And what's interesting about those studies, there was one with low molecular weight heparin that was given for 10 days, and then patients were randomized to aspirin or low molecular weight heparin in total joint. The other one was rivaroxaban, where patients took that for 5 days. Then they were randomized to either aspirin or rivaroxaban, and aspirin was non-inferior, but you have to remember that they received that anticoagulant drug before randomization.
Gotcha.
So this is the only one I've seen that compared aspirin truly to anticoagulation.
I think that's a good point because people tend to misinterpret the studies and they see, aspirin was non-inferior to low molecular weight heparin, non-inferior to
It was rivaroxaban.
But if you look at the patients, they did not get aspirin all the way. And the orthopods, this is based in Canada, I think, to start with, if it was a high-risk patient, previous DVT or things like that, they did not want to use aspirin. So they would still use low molecular weight heparin or one of the DOACs.
Yeah. Talking about all the evidence, and we talk a lot about translating evidence into practice and how to. I think that's one topic we need to start talking about too. Is like, how do you decipher the different studies and what are you going to use in practice and what are you not, and what's a good study and what's not? Because I think a lot of providers, there are some that come from academics that are really good at that, but there are a lot of people in community facilities that just will read titles and not necessarily do deeper dives.
So we've taken that at our facility with Total Joint, where we have a very close relationship with the orthopedic joint group, and said, okay, aspirin's okay in your general patient. We're going to give you that because we're not going to stop them from using aspirin.
Yeah.
But here's the protocol as far as what the dose we find acceptable is, what the formulation is, and here's the patients where we don't want you to use aspirin. So we've basically picked our battles.
Yeah,
so patients with a significant thrombophilia, patients with cancer, patients with a family history of VTE. And when we just pick that group of patients we view at the highest risk, the orthopedic surgeons will basically listen to us and say, okay, for those patients, we won't use aspirin, we'll use an anticoagulant agent for VTE prophylaxis.
Yeah, that's a really good point, picking your battles, for sure.
One of the things I mentioned this morning on the risk calculators is you see a lot of articles are comparing them, saying, this one's better, this one's not better, and most people do not understand how they were derived, what their complications were, and therefore they misuse the risk calculators. So it's the same kind of thing. The anesthesiology paper that came out had an editorial that said you can't compare apples and oranges necessarily, but most people won't read the editorial.
Yeah,
they'll just read the first take.
I like that you said that, for sure. Thank you all very much for sitting down with us.
Thank you.
Thank you.
All right, great.
Top.
Cheers.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.